Good morning, everyone, and welcome back to Bringing Out the Ed. I'm Dr. Jonathan Barr, aka MD4 from Cooper Medical Command, and this time we'll be taking on hypoglycemia. It can seem easy on the surface, but there's some details and we're going to go over it today. So let's first talk about a case that I assume many EMS providers have seen before. We have a 72-year-old female with history of diabetes, presents with altered mental status. You arrive, the patient's acting bizarre. You check her sugar, find that it's 30, give some D10 solution. Patient wakes up, feels back to normal, eats a sandwich, says they feel fine. You recheck the sugar, it's 120 now. What do? Send them home, right? Have them refuse, case closed, game over. That's it. All you need to do, right? Well, not totally. You need to ask yourself and ask the patient and talk to the patient about why this happened. And that's really the purpose of this lecture today, is to really get into the why and understand when it's safe for these patients to refuse. So let's think about hypoglycemia. I think it's easy to think of it into two categories. There's hypoglycemic patients who don't have a history of diabetes. Now, if you don't have diabetes and your blood sugar is low, then you should start to wonder, do you have one of these things going on? And these patients, I'd recommend all be transported to the hospital, if at all possible, because they probably have something serious or something bad going on. Then there's the more common category of people with diabetes, and in the most common scenario of the hypoglycemic patient with diabetes is either they took too much of their meds or they didn't eat enough or something along those lines. But the question, what you really need to figure out is, what are the meds? Because that's going to change how safe it is for them to refuse or not. So before we get any further, I'm going to talk about a lot of different drug names and a lot of different diabetes meds. I'm going to give the generic and the brand names. I don't have any financial conflict of interest about any of these drugs. I have no stake in these drug companies. I don't get paid by the drug companies, so I don't have anything to kind of hide with this. I don't have any stake in any of these drugs, but I am going to tell you about them so you understand what you're looking for out there. So first things first, let's just start with insulin, right? So patients who take insulin or insulin analogs basically are taking a form of insulin to replace the natural insulin to lower the blood sugar. That's basically how it works. It replaces what was already in the body or what should have been in the body. How long does it last? Well, we're going to get into that, but they're both short and long-acting insulin, and it's important to know which exact kind your patient took. Now, can these patients get hypoglycemic again? So when you walk out of there, how do you know they're not going to drop their sugar again? Well, it's tough, and it's especially tough if they took a long-acting insulin, so it's important for you to understand that and counsel the patient appropriately. And there's a lot of brands, so let's look at them. Let's look at it real quick. Let's look at this chart here. So this kind of groups the insulins by their onset of action and also their duration. So you have your rapid and your short-acting, and probably the common ones you heard are all right here. Insulin aspart or Lispro, Novolog, and Humalog are probably the two most common. They're quick to onset, and they last a good bit, so keep that in mind. Now, typically, these are used as correctional insulin, so the insulin the patient takes after they eat a meal. There's also short-acting insulins like regular insulin. So this is the closest to the insulin that your body makes. Some people use this as correctional. This is also often used in the ED for insulin drips, hyperkalemia, calcium channel, beta blocker toxicity, other indications. Less common, I would say, for people to be taking at home, but you might encounter it. Then there's the intermediate acting, which are the tricky one, which is the NPH insulin, sometimes called Humulin. And this could either be a basal or prandial. The regimens vary, but you need to ask the patient what they're doing with it. But keep in mind how long these last. You notice how the time's going up, the max time. And by the way, I'm listing a range here because it's going to vary slightly based on the exact formulation. And I'm also listing a range because it's going to vary based on the patient's other comorbidities like their renal function, things like that. It tends to be, if you have renal disease, the insulin sticks around a little longer. So that's why you're seeing a range here, because this is the reported range for the drugs on the drug inserts. Now, here's where you start to get into the ones that can maybe get you into trouble. They're longer acting. You can see they last up to 30 hours, and these are often used as a basal insulin. So you'll take them either once or twice a day. And this is your Lantus or your Levemir. Those are probably the two most common ones there, okay? And then now you're starting to get into these premixed ratios. So these are mixtures of an intermediate form of aspart, kind of aspart protamine. This is different than the regular aspart that you see up here, than your rapid Novolog. And there's also a Lispro version of this, and these are often in like a 70-30 or 75-25 or a 50-50, and these are often used without prandial correction. So endocrinologists or someone has put patients on this. If the patient's having trouble adhering to an insulin regimen, they can just take this and then that's it. Now this works fine, except the patient has to eat the same amount every time. If they change their carb intake, they're not adjusting the insulin, and so they can get into trouble if they don't eat. So these are the patients who are going to get in trouble if they don't eat, okay? So that's the ones you have to look out for that, and you have to look for these kind of mix. Some of them you'll see listed as 70-30, Novolog 70-30, or Humalog 75-25, probably the most common. So you should watch out for these different insulin types. Now the important thing in terms of refusing is the longer acting insulins, patients more likely to get hypoglycemic again, okay? So you want to really kind of look out for those there, okay? Now, metformin. So metformin, really common diabetes med. How does it work? It inhibits gluconeogenesis, it makes less substrate for gluconeogenesis, and it improves insulin sensitivity. Notice how it doesn't cause your body to make any more insulin. That's really important for metformin. Half-life, you can see it here. But the important thing is, like I said, it doesn't stimulate you to make any insulin. It's not giving you any insulin. So the risk of getting hypoglycemic from metformin is very low to almost non-existent. You're more likely to have other toxicity from metformin, like lactic acidosis or something else. So hypoglycemia is not common in metformin, but it is a common diabetes med, and you should keep an eye on it out there. These are the common brand names of it. So if you see the brand name, these are probably the most common ones. Next class is the sulfonylureas. So these work by stimulating insulin release. Again, very important. They stimulate insulin, okay? So you're getting more insulin from this. You're also increasing insulin sensitivity. And also, look at these. Some of these duration of actions are pretty close to a day, to 24 hours. So this class of medication has a high risk of recurrent hypoglycemia. Again, a high risk of recurrent hypoglycemia. Now, these are some of the common brands you'll probably see here. Probably glyburide and glipizide are probably the most common. Now, those are kind of like the older classes of diabetes meds, but now you might start to see some of these newer ones, and so you have to be aware of them because they all work differently. So, one are the GLP receptor agonists. So GLP-1 is sometimes also called incretin. These work by basically being an analog of this hormone. This does increase insulin secretion, decrease glucagon, as well as increase the beta cell growth, delay the gastric emptying, and decrease the food intake. And that's really important because that's why everyone's prescribing these, because they can also help with weight. And so a lot of people are switching to these because they're helping diabetics lose weight as well. Okay, these are the most common ones, probably exenatide, semaglutide, and liraglutide are probably the ones you'd see, and you'd see how their half-lives vary. So they last different amounts of time, including up to 1 week in some. So how about the risk of hypoglycemia? Now remember I said that they increase insulin secretion. So there is an increased risk of recurrent hypoglycemia, but it's not as bad as the sulfonylureas, maybe a little worse than metformin, but it's not as bad as sulfonylureas. However, it is possible, and not only that, it's more likely to happen if the patient is also taking other diabetes meds, which they all often are. So you can have a sulfonylurea plus this, or you can have other things plus this, and so you really have to watch out for that. So that's really the issues you can run into here. And you may not recognize these names up here, but you may recognize these brand names such as Byetta or Ozempic. I think everyone knows that commercial, or Victoza. And they're, just so you know, these are injection forms, which is important for you to know, because sometimes the patient says, oh, I take shots for my diabetes. Make sure they're actually talking about insulin. Most of us will interpret that to mean insulin, but they might be talking about one of these. So just something to keep in mind is just because they say they're taking shots, they might actually be on one of these medications, not just insulin. Now, there are a lot of other ones of these, but if you don't know what it is, just look for the ending. It should end in "ide." Like all these, the exenatide, semaglutide, liraglutide, they all end in that glutide, okay? Now, a close cousin of these are the DDP4 inhibitors. So they don't increase, they're not analogs of incretin directly, but they block the enzyme leading to increased levels of incretin. And so it kind of works similarly to the GLP-1s I just mentioned. And these are the gliptins, right? So sitagliptin, linagliptin, you can see how long they last. Similar hypoglycemic risk to the GLP-1s. And you probably have heard of Januvia, at least. And there are a lot of other ones of these, but just remember, look for the gliptin, and that's the key way to determine if it's one of these that you're dealing with. Now, moving on to a totally different class, the sodium glucose CoA2 transporters. Now, these work by basically reducing glucose reabsorption in the kidney, so they basically make you pee out glucose. That's basically what happens here. Now, these are the flozins, canagliflozin, dapagliflozin, okay? You can see the half-lives here, how long they last. Now, it is possible to get hypoglycemic with this, but it's less likely, okay? Because you'll pee out less sugar as your blood sugar in the serum falls, so you're unlikely to get hypoglycemic. It is possible, though, in combination, especially with other agents. The key thing here is DKA. These increase the risk of DKA, and they also can cause a quote-unquote euglycemic DKA, where the sugar is not that high, where it's less than 250. And this can trick you. You get a sugar, oh, it's not that hard, it's not bad, it's probably not DKA. This can fool you, okay? So if you see people on a flozin, you might have to worry about euglycemic DKA. So you have to watch out for that, okay? And you probably heard some of these brands, Invokana, Farxiga, okay? Some of the brand names patient might tell you they're on, all right? Next up here, we have the thiazolinidiones. That's a mouthful there. But you can remember these as the glitazones, okay? And these work on increasing insulin sensitivity, and they decrease glucose production by the liver. Notice how they're not affecting insulin production here. So as a result, they have a pretty low risk of hypoglycemia. But again, if you start adding lots of diabetes meds together, it can happen. In the US, I believe there are only 2 that are on the market, Avandia and Actos. But there are some others around the world. Just look for the glitazone there. Excuse me. Now, you might be wondering, do I need ALS on these patients? In general, hypoglycemic patients should have an ALS unit involved, especially if they're altered, because they may need some D50 or D10, whatever your local protocol dictates. I would advocate for D10. So you will likely need ALS for that. So in general, ALS on these calls. Now, you might be wondering, well, okay, we corrected the blood sugar, doc. Can't this patient just refuse? We've been doing this for a while now. The answer is it depends, right? So these are the criteria that I would suggest to help you determine if refusal is safe. So 1, the patient should have a history of diabetes. If they don't have a history of diabetes and they're hypoglycemic, there's something else bad going on and you need to take that person to the hospital. 2, their post-treatment glucose should be greater than 80, so they have to respond to whatever therapy you gave them, be it PO glucose or D10. They should be tolerating PO now, because if they can't eat, then their sugar can go down again. They should have a doctor who follows up with them. No sulfonylureas. It's just setting yourself up for something bad to happen. You're at high risk of recurrent hypoglycemia here, and so you should really advocate these patients go to the hospital if you can at all possible. In an ideal world, the patient should also have a responsible adult there, so if they do get low again, someone is checking their sugars and someone can deal with it, okay? Because you want them to monitor their sugar closely for a few hours, because like I showed you, most of those meds last for quite a while. So you need to watch out that they don't drop again over the next several hours. And then you also have to watch out for complicating medical conditions or comorbidities. Again, I mentioned renal disease for one. Like these meds, often their clearance gets affected by the renal function, and that's probably a common reason why some of these, the patient will have had a change in renal function, didn't change their medication dose, and now it lasts too long, and they get low for that reason. So those are the important things to do. So in general, I'd encourage these patients to go to the hospital for glucose monitoring. But in general, if they meet these criteria, it's probably safe. Always best to advocate these patients go get checked out and have their glucose monitored in a monitored setting, but many of them don't want to go. And so these are the criteria you should look for to really help you determine the safety of that, and also to counsel the patient appropriately on the risks and benefits of their decision, okay? Now, when in doubt, call Medic Command, okay? If you call I recommend you call Medical Command for all these hypoglycemic patients because there are so many new meds. You might not know what all the meds are, and so let a doctor who has to know what they all are discuss it with the patient, discuss the risks of recurrent hypoglycemia, and having that conversation can be really good for the patient to get them education. It can be good for you, and also helps make sure that if you are going to do a refusal, that it's a safe one. And so if you have online medical control as an option for you, it's a good choice. It's a good option for you to call. Thank you guys for listening in. Stay safe out there. MD